Thank you for joining this latest episode of ACRO Podcast. It is my distinct pleasure to introduce our host again for today's program, Dr. Brian Lally from Penn Medicine. Dr. Lally, thanks for hosting tonight's program.
Thanks, Fraser. I'm very excited today because I get to meet one of our corporate sponsors who was at our recent annual meeting down in Fort Lauderdale, where I hope that everyone else had as good a time as I did. Today, we're going to be talking with Angel Rodriguez from Natera. Angel, why don't you introduce yourself?
Absolutely. Thank you, Brian. So my name is Angel Rodriguez. I'm a medical oncologist based out of Austin, Texas, and I'm a medical director here at Natera in the oncology department. I've been here for about 2 years and really excited again as well to talk today about this new powerful tool that we have in the clinic.
So Angel, before we begin, tonight's the night when UNC plays Kansas in the championship game for college basketball. I just wanted to ask as a first question, how'd you do in your pool this year?
Sure, yeah. So I did not do too well. Actually, my original pick, my original pick was Duke. I am an ACC guy. I'm a yellow jacket, so I tend to pick, most of the ACC teams. But I got it wrong with UNC, with Coach K and UNC. So yeah.
Well, that's a shame because I had UNC from the beginning. But we'll come back to that later.
Sure.
Let's talk a little bit about Natera and Signatera. Can you explain the difference between Signatera and other tests that are out there that don't require tissue specimens?
Sure. Yeah, definitely. Absolutely. And I think, I like to start to answer that question by, always when we all kind of went into oncology, I'm sure that at some point during our training, we asked ourselves, will we ever have a blood test that will be able to tell us, if a patient's disease was, eradicated or, taken out completely by surgery or eradicated by chemo and radiation. And I think we all really knew that a test like this was eventually going to happen. And so, here comes, this test that we call Signatera. It's a personalized tumor-informed ctDNA test. So, me early on in about maybe 2013, 2014 is when I first got exposed to, the technology of ctDNA for the purpose of identifying molecular alterations that could then give us important information of how we could or should treat our patients. And it's been a remarkable technology. It really has revolutionized how we treat our patients in the metastatic setting and how we, pick the best treatment option up front. Now, with that, one was able to also sort of see that, changes in ctDNA levels, could track with treatment response. But in the setting after patient had, neoadjuvant treatment and after surgery, these tests were just not sensitive enough to be able to answer the question, is the disease still there? And to use the test the way our hematology colleagues use them, right? Patients with CML or acute leukemia. And so herein comes the approach of performing whole exome sequencing on a tumor and performing whole exome sequencing on germline blood. And with that, of sequencing of roughly 20,000 genes, one then can come up with approximately 50 to 200 mutations that are unique to each patient's cancer and that may or may not be cancer related, these mutations that we find. And so with that, we can now design a personalized assay for each patient, a test that tracks up to, that tracks 16 mutations, 16 variants, multiple variants. And that way we can enhance the sensitivity in the event that the concentration of ctDNA in the patient's blood is so low that tracking one or two variants is just not good enough. We track up to 16.
That's interesting. So how does Signatera capture tumor heterogeneity from this single biopsy?
Yeah, exactly. So we certainly do know that heterogeneity exists. It happens in tumor, much like it sort of branches into different sort of subtypes of within one cancer. And so when we do whole exome sequencing and we identify somatic mutations, we do look at the variant allele frequency expressed within the tissue. And so those mutations that are found at highest frequency are the ones that are most likely to be clonal in nature. So if we then identify 16 mutations that are clonal, and we track this over the lifetime of that patient's disease as it's being treated, it's extremely unlikely that all 16 clonal mutations that were originally identified will be lost over time. Now, it may be that several of them will be lost because of heterogeneity, but it is unlikely that all 16 will be lost. So, starting off with these clonal mutations allows this to be a lifelong personalized tumor marker.
That's really interesting. So, someone like me, I think I'm your typical ACRO member where I treat 20 to 30 patients every day. And so integrating it into patient care is critical for me. I wonder if you could explain to me what is meant by a personalized MRD assay and how Natera can help to be used to clarify some scans that may be indeterminate otherwise.
Yeah, absolutely. So first of all, what's unique here, this sophisticated approach of doing sequencing on each patient's tumor and then coming up with an assay that is personal. I mean, that's exactly the point. Not every patient is going to have the same cancer, the same mutations within each cancer, and therefore not every patient is going to have, or not every patient should have, the same biomarker. Right? Each patient, because they have a unique tumor with unique mutations, really deserves and should have a reliable marker that is tracking mutations that are unique to that patient's tumor. And so then also what's also remarkable about this is that, when you are tracking multiple mutations and you ultimately detect and quantify the levels of each mutation, when you then report this or do the mean tumor molecules per milliliter average, you're able to better quantify, more accurately quantify the tumor burden for each patient. And so, with this approach that's been now clinically validated across multiple tumor types, and really the data being most advanced in, let's say, in colorectal cancer, where, today, we do have Medicare coverage, LCD coverage for the use in stage 1, 2, 3, and stage 4 disease that's been completely resected. We're now able to use that test to determine, is there molecular disease left after surgery? Because if we know that, and there is, you're considering not offering that patient chemotherapy, that patient, has a 98% chance of recurrence. And also it's been shown that at least we have chemotherapy that can modify that risk, that can reduce that recurrence risk.
So what you're trying to tell me now, and I just want to make sure I'm getting this clear, is like I treat a patient, and it's, whether it's lung or colorectal or something like that, I get these imaging studies. I love looking at imaging studies. The problem is when I look at those imaging studies, it's hard for me to tell whether it represents scar or live tumor. Do you think that, clearing the circulating tumor DNA can be a possible surrogate for determined this response?
Yeah, I think what we can definitely conclude today is that clearance of ctDNA is essential and necessary to achieve a cure. So a patient that we hope has a chance that you've eradicated all disease and recurrence is not going to happen must have cleared ctDNA. There must be no evidence of molecular disease. Now, if a patient did not clear their ctDNA, that's a patient that, again, will have recurrence if nothing else differently is done. Now, but what we also have to keep in mind is that clearance of ctDNA may not be sufficient. It may not be sufficient to achieve a cure. There are a percentage of patients that will clear their ctDNA, but may eventually have a relapse. Now, to me, what is most exciting moving forward in this field is for us to better define and refine how do we determine which patients are cured based on the dynamic changes. So what I'm trying to mean is that when ctDNA clears early, what we're seeing is that those are the patients that are most likely to have the best outcome. We've seen that in rectal cancer. We've seen that in breast cancer. Those patients who clear early are the ones that are most likely to achieve a cure with the treatment that we're offering them.
So that's how we define a curative intent, correct?
Correct. Yeah.
That's what you're trying to tell me, correct? If we
Yeah.
clear it, then we have really done, knowing that status helps to define what curative intent is, correct? If I'm not mistaken that.
Yeah.
Okay. So I guess that leads me to my next question. When I'm surveilling patients, how do we use this tool or technology to manage those patients? And what do we do when we have indeterminate findings on imaging studies? How do we pull everything together?
Yeah, that's exactly right. I think we have to answer that question based on the different scenarios, different tumor types. And so the easiest one is, for example, let's say colorectal cancer, where today we already have established guidelines, established ways of how we do surveillance on our patients. Well, this is a test that can complement CT scans and CEA. And by adding the ctDNA, we're able to have a more accurate assay that can potentially clarify not just equivocal imaging findings, but results with the CEA, right? CEA is not perfect. The accuracy is hampered by the fact that it can give us false positive results. And so here's a test, or also, false negative results. So having a result with ctDNA can complement our ability to, by the way, sometimes seeing an equivocal imaging finding, knowing that ctDNA is positive can sometimes, help us better interpret findings that we thought may not have been disease, but now that we see molecular evidence of disease, it's more likely to be actual disease, real disease.
It's really exciting. So these are some of the areas that I find challenging as to knowing what the right thing is to do. And I'm just kind of curious if, with Signatera, if you could tell me what the clinical indications are that are approved and where you see in this being area of future research that could find a clinical indication. Two areas that frustrate me with knowing what the right thing is to do is some of the high-risk prostate cancers and some of the oligometastatic diseases like lung, colon, sarcoma. What role can we find for Signatera in those settings, and what has been approved already?
Yeah. So I'll start with what has already been approved for what there is already coverage by Medicare or local coverage determination, and that is early stage 1, 2, 3 colorectal cancer, as well as resected oligometastatic colorectal cancer, and it can be used with the purpose of checking post-operatively, roughly 4 weeks after surgery, 4 to 8 weeks after surgery. If there is detectable ctDNA, you can bet your bottom dollar that patient has residual disease that is destined to relapse, and that chemotherapy, will be the main option that can clear and prevent that disease from recurring in the future. For immunotherapy treatment monitoring, based on really nice data generated with Princess Margaret Cancer Center, we also have coverage where in the setting of patients being treated in the metastatic disease with immunotherapy, this test can complement CT scans and imaging findings to know whether the patient's benefiting from treatment or not. Now, in the settings that you have described, oligometastatic disease, I think that there, depending on the tumor type and the scenario, I think the standard of care is sometimes not clear to all of us, right? When do we offer adjuvant systemic therapy and when do we not offer adjuvant systemic therapy? And I think all the other factors that we use to determine whether we will offer or we think our patient benefits from treatment should be included along with this piece of information that can be the key to guiding or having a patient decide whether they want to go through, more adjuvant chemotherapy in that setting or changing systemic therapy for that matter.
Or even adding stereotactic body radiotherapy. I mean,
that's exactly, yeah.
Because that's where, where we're going at sometimes as radiation oncologists, trying to figure out the hammer to use at the right time.
Yeah, so you can imagine if you eradicate ctDNA in the setting of treating locally with local regional therapy and the ctDNA cleared, then that's a patient that you may not want to change systemic therapy. That's a patient that you may not want to add systemic therapy. But if the ctDNA didn't clear after that scenario, then maybe a medical oncologist could decide that too. So I think this piece of information can be very valuable.
That's great to know. This has been really helpful, and I've enjoyed talking to you today. I did want to ask you, what's your pick for tonight, Kansas or UNC?
Again, being an ACC guy, I am going to go with UNC.
Go Tar Heels, right?
Yep, go Tar Heels.
All right, I
Yeah.
just wanted to say thank you again, and I'm going to turn it back over to Frazier to wrap this up. Are you there, Frazier?
Terrific. Thank you very much, Brian and Angel. Appreciate everybody's time today. And we hope everybody that gets to view this content enjoys and finds it beneficial. We would like to thank our production team for putting this together. And of course, our host, Dr. Lally, for hosting tonight's event. And thank you to Natera for being here, and Angel. And hope everybody has a great evening.
We really want to thank Natera for being one of our corporate sponsors and for doing all their support of the meeting and our educational goals. I can't state how important that is and how much we appreciate everything they've done.
Thank you, Frazier, and thank you, Dr. Lally. And yeah, keep your eyes peeled, around this field, this technology, because it's data's generating quite fast, and it really truly is very exciting. Thank you for having us.
We enjoyed it. Stay safe, and I hope to see you next year's meeting. Is that okay, Angel?
Absolutely. Looking forward to it.